let's just say that, again, for the discussion paper, this guy he's very active. He's already received his Sapulus LT. We know he has multiple areas on his bone scan to the axial skeleton, the ribs, sacrum. He's got minimal nodal disease, less than 1 centimeter. So we talked to him and say he is getting up at night and taking more and more NSAIDs, occasionally takes an opioid. Dan, with all the different therapies that are out there, this guy's already failed, he's progressing past his immunotherapy. Sort of how do you look at this gentleman now?
So the first thing that strikes me about this case is he's only had a sodium fluoride PET scan. And recently, in my experience, there is a CT scan that's often done with that. But the CT scan generally is not a high-resolution CT scan. So you may be missing visceral disease in a patient such as this. So the first thing I would do in this patient is get a standard CT chest, abdomen, pelvis with contrast to be sure that he doesn't have liver mets or something else that we're missing in the situation. And that's going to affect my treatment because clearly if he has visceral disease, I'm going to tend to go more towards chemotherapy. If he has bone-only disease or nodal disease, I would like to go with enzalutamide or abiraterone in that situation. So I think that that's going to be one of my checkpoints.
So so let's just say he's got a full-blown CT, no visceral mets, multiple bony mets, 1 centimeter node, ECOG 1, and some symptomatology that seems to be related to his bony mets in terms of some mild pain requiring NSAIDs, but occasionally will drop an opiate.
Right. So I think that either abiraterone or enzalutamide would be appropriate in this patient. Certainly, there are selection criteria for both drugs. Somebody who's older and frail, I would not tend to give enzalutamide to because of some of the CNS effects that go on with that, the fatigue that goes on with the drug. But I would either consider Abby or Enza in this patient. I think it's a toss-up as to which one to use in this situation.
Mike?
Yeah, I mean, I think his point is well taken. One of the things that I'm impressed with as a urologist is that we see windows of opportunity for treatment, and sometimes we get complacent with what we're doing, and then we lose those opportunities. So, for example, yes, the oral agents would be appropriate in this setting, but if he's having pain and it's related to the bone, and he doesn't have visceral metastases, there's a window open there for you to give radium. If we don't do it, and let's say it's a year later and now he does blossom visceral metastases, we're taught not to give the drug in that setting. So I think that there's a lot of competing issues, but one of the things that I worry about, and the same is true of immunotherapy, we lose some opportunities while we're watching, and we may not watch often enough. So I think that the agents we've discussed are certainly appropriate, and I think if there is soft tissue disease, I think visceral metastases, I think the trend is more towards chemotherapy in that setting.
So David, obviously in 2010, pre-2010, docetaxel was the only thing out there. Sort of how does docetaxel fit into this patient? It's clearly an option.
Right. But most patients want to wait with the chemo. And I think that we have other options now. So this is a patient where I'll say, well, okay, chemotherapy is a well-tested treatment. It's going to be in your future unless they're really not a candidate for it. But I would tend to reserve that for a patient that either has major opioid requiring pain or visceral metastases. So in this patient, the discussion I'd be having is between one of the novel anti-androgen drugs, either enzalutamide or abiraterone. He's 63. I think he'd tolerate either reasonably well. Or whether we start now with radium because he's kind of in the window. And what do I mean by the window? He doesn't have visceral disease, and I would do the CT scan with contrast, just as Dan Petrylak would, because that's something you really need to know if you're considering radium. So I would talk to this guy about radium, and I would then say, if we do radium, we're going to have to watch you closely. We'll see you each month. We look at your PSA. We'll look at how you're responding. We'll look at your alkaline phosphatase. And I think you might do well with that for a period of time because he has an active bone milieu. One thing that would worry me about radium is that he has a PSA doubling time that is now less than 6 or 7 months. And radium's not great at controlling the PSA. So the discussion then is, well, if we need to add something to control that, what are we going to do? And so I would potentially start him on radium and then say, look, my threshold for starting either enzalutamide or abiraterone, if I've got to control your PSA, is low. And then the other thing is I do a scan between the 3rd and 4th radium treatments. I don't even do a bone scan anymore because usually the radium's very effective. If it's not, the patient's getting increased pain and that hones you in. But I've had a number of people who've started to develop visceral metastases. And in this guy, I wouldn't be so worried because I think I can control that with enzalutamide or abiraterone. But when you're looking at giving radium a bit later, you start to get visceral mets in either the lung or the liver or elsewhere. Sometimes if they're resistant to enzalutamide or abiraterone or both, it can really rock it along. So there's a lot of different considerations there.
So clearly, if you got a scan, maybe not in this particular patient, but a rapidly progressing patient in between 3rd and 4th injections of radium, and you picked up newly diagnosed visceral disease, you would have probably had them on another agent as well. Would you complete the last 3 cycles of your radium-223?
So the answer is maybe. All right. So the guy at the moment, I think, has got evidence of an active bone milieu. So if he says, look, my pain is improved, and the spouse agrees, and he's getting benefit from it, you've then got a difficult decision to make. And it depends what drugs they've had before. This guy, if he's not had enzalutamide or abiraterone, they're good choices. The more difficult choice is when you've got small liver mets and it's the first time. Do you add docetaxel to the radium, which has excess toxicity? We know from the phase 1-2 studies done by Mike Morris and other people out of Memorial Sloan Kettering, that you can't give full doses of both.
Right.
So it's an issue of whether you're going to change it up and extend the interval of radium and reduce the dose of docetaxel in that setting. And I think that's a difficult question. Would they do as well with just switching to full dose docetaxel at that setting? This doesn't come up that often,
Right.
but when it does, I've learnt that we may be going over a cliff with that patient, and you need to be prepared to react pretty quickly.